So now we're going to discuss some of what we've just heard. So I'd like to welcome back to the stage some of today's previous speakers, and I will reintroduce them to you as we hustle them up to take their seats. Dr. Chris Gynell, Team Leader of the Biomedical Ethics Research Group at the Murdoch Children's Research Institute. Professor Andrew Wilson, who we just heard from, Chair of the Pharmaceutical Benefits Advisory Committee, and Anne Single from the Patient Voice Initiative, immediately preceding me. And I would also like to introduce you to Hayley Andersen, Head of Patient Advocacy at Bristol-Myers Squibb. Hayley works to bring patient perspectives to company decisions and actively supports the patient voice in health decision making. Hayley was formerly the CEO of Melanoma Patients Australia and has a strong appreciation of the issues Australian patients face. Welcome to the panel, and to Richard Vines, who's going to lead the discussion. Thank you.
Well, welcome everyone, and thanks again for everybody who has participated so far today. It's been an amazingly diverse discussion, and thank you all. I think it's only fair because we've heard from everybody else, so I think it's good that we start and hear from Hayley. And we've had a lot of disruptive and interesting conversations today. It would be just good, perhaps, if you could share your perspectives on what's been shared so far, Hayley.
Thanks, Richard. I think my perspective on all of this will be much better in 3 days when I've had a chance to think about it all. But overwhelmingly, I suppose it's been it's compelling. The impetus for change is there, and I think that there is wide support for that change. We've got a system that does prioritise cost effectiveness, and that construct should take into account and theoretically does take into account a patient's experience and their quality of life and things like that. But we don't always do it well. Some of those instruments to measure those sorts of things aren't great, and so I think industry can do better in that respect. And I think there's wide support also for complementary inputs to the HTAi process that will help the decision making, and some of the value discussions today certainly would be that.
Last year we had a report released on the rights and roles, and Jane Tiller, who's a colleague of Chris's, gave a talk, and she talked extensively about the social contract, and she defined the 3 pillars of that contract as being government, medicos and patients. And I reflected after and thought that we missed out on one, which is industry. The pharma industry is a key pillar in this particular process. And I was interested in how you see industry should form part of the social contract and this whole process. It can't just be as a provider. It's more complex than that, I would have thought.
It is more complex than that, and I think that the industry absolutely does have a role and should be is an important stakeholder. I think there's a job that industry needs to do and deliver upon, and I think you've said to me many times that you've never met anyone in all of this game that isn't doing it for the love of it and for the right reasons. And I think we can work together to identify the things that we have in common, the common outcomes we want to achieve, maintaining independence, maintaining our own roles, but I think we can work toward those goals.
Yeah. Chris, you asked us an enormous number of questions, and brilliantly so. How are we meant to balance the moral and ethical questions? We're all sitting here sort of thinking, we're all in trauma after what you've thrown and confronted us with. It's not easy, is it?
It's very, very hard, and I'm lucky in a sense because I do work in academia and philosophy where all these are sort of idealised problems where you can think about them in the abstract, and once you start to apply them in the real world, it gets really, really messy. And I was struck by what Andrew's talk about, well, there's different questions here because there's, first of all, how much should we spend on health? How much should the bucket be? And I think for me personally, and a lot of people will think, well, government should be spending more on health in general. The bucket should be bigger. I mean, do we really need to spend billions building nuclear submarines when people's cancers are going untreated? So that's one question, and that's, a political question. But then the other question is, say we've got a fixed budget, we can't increase the size of the budget, how do we spend that? And that is a very tricky question.
I think that question about, we just accept that there's a health budget and we don't argue about it. And I remember years ago having a conversation with a lung cancer oncologist, and he said if I had 30 million to spend tomorrow, I'd spend it on prevention, not treatment. And I said, well, why not buy one less Joint Strike Fighter and do both? And I think that's really interesting, and I reflected on that issue with the fact that we're now looking at spending as a country 3.1 billion on new tanks. Now, the last two versions of tanks we've had, I don't think have ever fired a shot in anger. and you have to wonder whether we should broaden that process. And from an ethical perspective or a societal perspective, I'd be interested in where that argument leads us.
Yeah, I think we spent 200 million negotiating with France for submarines that we never bought. So there's clearly savings in other areas of the budget that we could be making.
Yeah, and it's interesting.
So there's an important issue there from my perspective.
Yep.
Those are issues of government. They're issues for Parliament to debate and decide on what what it wants to do in that regard. So parliaments in a democracy, parliaments decide on those sorts of things. They do. They decide, well, we're going to spend on this. There's also an underlying construct about the way people think about infrastructure differently within finance terms to costs which are recurrent. And, where the PBS is the largest, within the top, I think it's the top 5, if not the top 3 recurrent expenditures within the health budget within budgets within government at the moment. So there's a focus on it which is disproportionate in a way to the actual size of the spend because of the way it's seen in those sort of financial terms. And a lot of the things that we're talking about today, and again, I'm going to bang on about it again, is that the decision framework that you set has to be informed by these bigger picture decisions about the values that you want. If you want to change these things, if you want to do things differently, I'm certainly, very keen and in favour of that. But it's not a decision of the PBAC to decide to change the framework. That's a decision of the government. It's a decision of Parliament if it wants to, change the way these things are done. And we can, point government in directions, we can advocate in relation to it. But if you want to have that discussion, that's where we have to have it.
And I have to say, and thank you so much for being here today, but you have been totally consistent with saying if you want change, go to the big house. You have said that to me so many times, and it's absolutely correct that if we want a different system, the answer lies in...
Not far from here.
Not far from here at all, no. So I guess it does lead to the question, Andrew, that two questions. One is that, and I don't know if it's appropriate to even ask or if you'll be able to answer, but do you think that sometimes when we've talked about the issues of patient impact and value, that companies who are making submissions to both the TGA and the PBAC are not being adventurous enough or expansive enough in their submissions? And do you have a vision that you can share of what an improved system, what the outcome of the HTAi, what are some of the things that might be good there?
Yeah, so so the PBAC is a submission-driven process. We cannot generate our own submissions for applications. So we are dependent on either on a sponsor or an interest group in bringing forward a submission in relation to this. That can mean that a sponsor, a company, may choose to not bring forward the full range of options that are available. The full spectrum of a disease that a drug might be relevant to in when they bring it to us. So, they may choose a narrower population, usually because that narrower population means that it'll be more cost effective and more affordable. So they're just, they're just reading the guidelines and saying, "Oh, this is how we're going to get the drug listed." So that's, it's not. There's no. They're following the logic of what's there at the moment in doing so, but that is potentially a significant disadvantage to patients. The other, situation, as I said, is where there's actually, the drug is just not registered for that purpose, and there may be no evidence to support that registration process. So where do we go to with that? So we've had some recent examples where there have been particular subtypes of cancers, particularly hematological cancers, where that subtype was either not present in the trials or in such small numbers that you couldn't really make a judgment about it. And we made a judgment to say, well, okay, we're going to include all of those cancers because, well, we'll never know what's going to happen in that particular subtype. And we could do that because it was a relatively small number. It wasn't going to have a big impact on the overall cost of it, and it certainly wasn't going to probably make much of a difference to the cost effectiveness in relation to that. What I was saying in my talk is that it would be nice to actually have some recognition of our ability to do that, so that we can actually be more proactive in extending these indications in situations where we know we're never going to get evidence for it. And at the moment, we talk about acts of omission and acts of commission in our decision making. So an act of omission is when we leave something out that's important. So when we don't put an age limit in, then that's an act of omission, and that means that clinicians then make a decision in conjunction with the patient about whether or not, or family in the case of paediatric, in the case of children, about whether it's appropriate to use the drug then. Acts of commission is when we specifically say for a particular group, particular cancer, we're now going to treat that cancer even though it's not approved for that indication. That's a much more difficult situation for us. It's not clear that we can legally do that, and so that's an area that I think we would really like to have some clarity that would help for situations, as we heard, for example, with GIST.
Yep, fair enough. And we've talked a lot about patient experience and patient outcomes, but there's also there's two ways to look at the way you see patients as part of the HTAi process. One is, as we've discussed, patient experience and consequences, but there's also what we can refer to as, if we like, as patient participation, but you can also refer to it as patient democratization, which is going back to this point I think that Coleman made about that in First Nations people having a voice and being part of decisions that affect them. And where do you see that in the context of where we're at? And is it goes sort of towards the end of your speech at the end, but I thought it would be good to have a chat about it.
Yeah, I think this is really interesting because I think there was a real battle in the early days to get what was missing in the evidence, and we've built quite a bit of knowledge there, and unfortunately we have to duplicate it quite a bit. People have to resubmit it around the world. But I think what's emerged is the more patients have been involved in HTAi, the more they can see where the limits are and what's the barrier to it. And two good patient academics, Sophie Vercoe and Sophie Staniszewska, wrote about this not long about closing the gap in the evidence, and they talked about how sometimes our HTAi system can't really hear certain types of evidence because it's hard to integrate it into it. And so that's why I think now when we're talking about participation, we're talking about even just how we create HTAi and how we do, I don't mean recreate it, but reform it and change it and improve it, because if it was simple to do, someone would have already done it. But within patient communities, I think people have all sorts of ideas and discussions they want to have But HTAi is really hard to make sense of from the outside, and that's why I depict it as that box. And that's why we need the dialogue. So you can talk to people in HTAi and they say, well, the problem with that, and we heard it in some of Andrew's comments today, the problem with that would be this. Well, then you really want the patient community to say, well, is this an option then? We don't want the conversation to end there. And that's where I think we're going with this, because the health technologies keep on changing, and our understanding as a society and the values we have as a society are changing. But if we don't talk about health technology assessment a lot at the moment, it's because it's not easy for us to see it and to talk about it. But I think if it was more accessible and people understood, I can't believe I just went the people understood thing. I don't want to say people understood. But if people saw, I connect this dot with this dot, and that's why this is happening to me, then people would want to. Apologies for saying people understood. That's not what I meant to say.
And if anyone's got any doubts, I usually start every session I say with this, but at least half of you will end up as cancer patients. So the other half of you will end up looking after them. So we're all in this game. They're not a separate bunch of people. And I think that's really, really important.
So can I
yeah,
just
please.
follow on from that? So let's take a radical solution. Let's say that the PBAC equivalent became a patient that was a group of patients who are making the decisions about it, selected on some basis or whatever. Certainly it wouldn't worry me. But the same issues will arise. There will be a framework in which they will have to make decisions. There'll be requirements on them to consider HTAi probably as part of that process. There'll be requirements that they'll have to think about issues of the total cost to government. It won't change the nature there will still have to be a framework in which those decision makers have to work in relation. Well, it might do.
Of what is valued.
Yeah, it might do.
In yours, you were saying about the primary consideration is that cost effectiveness piece, and you're bound by that. You can consider other things, but you're bound by this construct that we have. So maybe with a new framework, we could have.
But only if you change the legislation.
Yes, of course. Yes.
That's what I'm trying to say. If you've got, it doesn't matter who sits at the decision making.
Yes.
Sorry, it does matter who sits at the decision making table. Of
Very
course, it
critical.
has to be me.
Critical.
But
No,
there is a framework in which you make
Yeah.
decisions, and
Yeah.
unless you change that framework, then you'll get some sort of similar constraints.
And sorry, I just interrupted, but I think what I'm not advocating is that we get rid of our committee and just have patients in charge, because I think everyone in that committee, along with patients, have expertise to bring to that conversation. But within individual HTAs, there's a lot of heat in that discussion. We're making recommendations in an HTA, but when we sit back and think about as a society what the processes we are, to have greater involvement of our patient communities in discussing what that framework looks like, and to buy into the complexities and the difficulties of it. In that Validate work they're doing in Europe, why I'm interested in that is because what it does, it teases out some of the difficult value judgments. But what it says is, these don't just belong to HTAi. Let's talk about this as a society, about what we believe there, because it's one thing to vote for a government, it's another thing to see them do all the things your heart dreams they will do. Sorry, microphone.
Yeah, can I just pick that up, because we started this conversation around Indigenous populations, and a lot of what we seem to be landing on is that the risk is something similar to a voice to Parliament. And I was interested in what Chris thought about having this patient democratisation and participation in a way that is not just measuring experiences, but actually having them have a voice and an influence.
Yeah, I think that would be an important part, not just for their sort of perspectives that they might bring to the table, but just the feeling that you're part of a decision-making process and you've got there. So I feel like people find it much harder to accept that if the decisions are being made in some glass room, some room where they can't see and there's no transparency there, I think having patients involved in the decisions and increasing transparency can help, have trust in the decisions that people actually make.
Yeah, I think that's right. I wrote It's a pity I haven't got Coleman on this panel, because when I was listening to his talk, he was talking about the social return on investment and the impact of it, and I kept thinking, if I calculated social return on investment, I think I'd spend less money on older people than younger people. And,
well, it's funny,
and I was a bit sensitive about that.
I've got to be careful too, because my mum's in the audience. But there's this remarkable statistic that 40% of the average health spend per person tends to happen in your last year of life. So it's when you're very, very sick and you're at a hospital and different things, fail. You need dialysis, then you need this, then you need this. And there's a lot of investment in that last month of life. And if you really wanted a radical solution, you could say, well, we're going to invest less after a certain age, and we're going to invest more in younger people, like, young mums and things like that. But that is very controversial, because you're basically saying when you get to an older age, yeah, we're going to invest less in your life now. So I think it is.
The response is go boomer.
Can I pick up on that as someone who might be approaching getting a bit older? I wondered, and I think it was there in the explanation about how over the years we've tried to put a value on life. So, that early value came from working out how much someone was going to earn in the rest of their life. For all of us in charity, what a horrifying idea that the value of our life will be how much we're about to earn in the next couple of years. But I wonder whether some of that sits when we make these things and we worry about whether we're going to not value older people. Because I would say as a society, we don't value our older people. And actually what's important is actually to be more clear and explicit about the value of our older people. And we'll find they're worth a lot.
Oh, I couldn't agree more.
Yeah, I think it's a very tricky. Of course, we spend most of our money in the last year of people's lives, because that's when people get sick.
Yeah,
That's now whether the money that we spend there is best, that we're using it in the best way we possibly could to provide care and support and comfort during that period of time is a very different question. And I think I'm not sure that there's much to be gained from trying to have that discussion if we frame it as that money is being wasted in that period of time.
It just comes back to the cost effectiveness question, though, because if you're going to apply all these cost effective measures to all these other new sort of treatments, then maybe you should apply in cost effectiveness to health spending across the board. And in that case, you're going to get less bang for your buck by spending money where people are going to die in the last month, sort of anyway. So I think it speaks to consistency, really, and values. No, sorry.
We'll just roll on from that. Could we talk a little bit about? There's so many. We've got 3.5 minutes left, but we've got. And by the way, we haven't taken questions from the audience because it's very difficult with such a large population online to try and make that coherent. And if you've ever sat through an AFL coach's interview after, you realise how impossible it is when you can't hear the question. So apologies, but and now having explained that, I've lost my place. Two things. One was I mentioned in my introduction the pan-tumour inquiry that that Greg Hunt dropped on you without consultation, and we can talk about him now. He's not here anymore. But I wondered whether you see some scope for that inside the upcoming review and the potential of it, because for a lot of rare cancers, it is almost the holy grail that we've got so many drugs available in the country at the moment that are not available for specific indications. I just wondered if we could get your view, Andrew.
Yeah, so I think one of the things about that inquiry was, it wasn't really an inquiry. The minister asked for advice from the PBAC on that particular issue. Is that the term pan-tumour means many things to different people, right? For people with rare cancers, it meant this is a way of extending access to those drugs to areas where there may be little or no evidence of benefit in relation to it. To sponsors, to companies, it was about, was there an approach, a simplified approach to the funding of immunotherapies that meant that they didn't have to put in an application, or at least as complicated an application every time they had an indication. So, so part of what we had to do in providing advice to the minister was tease those different elements apart and indicate which ones were feasibly within our remit and which ones weren't. I don't think it is a holy grail, but it is achievable and it will happen. It's not happening as fast as I want. That we will find a way of a simplified approach to funding PDL inhibitors. I think what we would like to get to is a series of prices which are agreed in relation to levels of effectiveness or some sort of gradient like that, and then basically if an agent is approved by the TGA for that particular cancer indication, then the application just argues that it goes into one or other slot, and then there's a relatively straightforward process for those. A bit like what we did with Hep C, but it's a bit more complicated than Hep C because of the outcomes that you're looking at are a bit more problematic in that regard. So I think it's achievable. It's just taking a while to get there in relation to that. The issue of the extension to these other ones goes back to the issue that I was talking about before and the challenges within that space, and it's not an easy discussion because we've been having this with the TGA about where they sit in relation to this, as you know, in relation to reuse of different drugs, repurposing, which has similarities in terms of this, but hopefully we can find a way through it.
Hayley, from an industry point of view, is there enthusiasm and excitement about doing this and getting it there, or challenges?
Well, I think that comes back. So I'm not a market access person, to be clear, but I think that does come back to the common goal of being patient access to medicine. So I think we have to work to different priorities will exist for different stakeholders, but we've got to work to that end that all of us want to get patients access to the medicines they need without waiting unduly.
Thanks.
And the one other thing that I was just thinking of then, Richard, was that comment that Sarah made around, what was it, blind acceptance of our systems. I think it's blind acceptance of the way things are being a barrier, and I think it's really terribly buoying, I suppose, to hear Andrew speak and have an appetite for change, because that's what we've got to have, that appetite for change if we're going to move things along.
Yeah, and we are forever grateful that you do the job that you do and that you turn up and care as much as you do, and the same for all of you. There's a big red screen in front of me which says time's up. I gleefully ignored it when I was doing my opening speech, but I think I better stop. So please thank the panel. They've been fantastic. Thank you.